Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. Today, I'm joined by Dr. Colleen Tewksbury. She's a PhD registered dietitian and assistant professor of nutrition science at the University of Pennsylvania. And Colleen and I have known each other for a really long time in the bariatric surgery field and the dietitian fields. We're chronic volunteer lovers and do lots of leadership stuff together. So I'm really excited to have this conversation with you. And today we're going to talk about the article that you were a co-author of in the Obesity Journal. It's on nutritional considerations with anti-obesity medications. And I really wanted to talk to you about this because this is obviously a very hot topic. And for us who've been in the field of nutrition and obesity and the surgical realm for a long time, I think there's so much we can offer to the topic. So thanks for joining me.
Thanks for having me, Nina.
So tell me, I think let's talk about the article a little bit first. I'm sure that'll bring us into some conversation about sort of the generals of the general things in the field that we know have been going on. So tell me a little bit about the new article that's out and how it might be helpful, who it's for, some of the main points.
Sure. So I was extremely fortunate to be invited to be a part of this paper and to be the primary dietitian representative, along with a fantastic group of bariatricians or endocrinologists who've been working in the field for a very long time, and also my colleague at University of Pennsylvania and psychologist Tom Wadden, which was very exciting. And the purpose of this paper, from an author standpoint and for the organizers, was to predominantly set up a reference document of what are some of the things for primary care providers. So this isn't intended to be per se for specialists. This is for general practitioners who may be new to working in chronic disease, chronic obesity treatment, and might not know some of what we've known for a very long time, nutrition-wise. So it is a summary of what are, and a narrative review, ultimately, of what are some of the best practices that we already know from other areas within weight management, that while we are waiting for higher level evidence, right, the studies that are currently being conducted to assess what do patients need nutritionally, while we are in the wait and we have all of these people being prescribed these medications, what information do we actually have? And to give some general guidance for general practitioners. This is not intended for subspecialists, and frankly, for most subspecialists and nutrition professionals, this may be old hat for them. A lot of what we're talking about.
That's good to know. Yeah, I think there's so many questions that people have. And I think one of the things that, again, is we've been working with people with severe obesity for so long, and we have a lot of good recommendations and a lot of good experience. We know a lot of the evidence-based practice is also about including the patient values. And I think that's a big part for this too, is we don't want to get into a situation where we come up with some new evidence and we start prescribing that and telling people what to do, because again, through our experience, we know that that's not how it works with the chronic disease of obesity, right?
Yeah, and that's also why we were very cautious with the language used. So you'll note, right, from a research standpoint and an academic standpoint, clinically, we don't call these recommendations. We don't call them guidelines. They're considerations. We do not have the evidence base for this just yet for the nutrition approaches with anti-obesity medications. So you'll note that much of this is not strong gatekeeping or directive language of what clinicians should and shouldn't do. There are considerations for clinicians, and what do we know, what do we not know? So you'll notice even around something like taking a multivitamin, that an individual might want to consider it. We do not explicitly state, because the evidence base isn't there, that all individuals on these medications should be taking a multivitamin, right? So much of the language chosen here was purposeful. for the co-authors, and very appreciative of all of the high level of thinking that went into this document. But being very cautious about how we phrase this to our colleagues, to patients. We don't quite know the best approach yet, but we know what's worked in the past for supporting individuals.
That's a really good point. I think that the language is always a really important consideration. So let's, kind of thinking about it from that lens for those who are going to go read this. I think it's a good way to look at that. So tell me, I know it's set up a little bit about like prior to treatment, during treatment, where can we have some impact? You want to take us through that a little bit?
Sure. So, again, for this document, not intended for dietitians per se, because much of it is what is in a nutrition assessment. There are things that we would expect from a standards of practice and professional performance standpoint when talking about our structured systems as dietitians are considered to be minimum level competent practice. So instead, what this is explaining for general practitioners or practitioners who may not be familiar in this area, what would we typically talk about or assess in a nutrition assessment, doing a 24-hour recall or a dietary recall, potentially assessing for general micronutrient deficiencies, any sort of risk factors that we might want to look out for. We have a very nice figure that summarizes this, along with what are some of the malnutrition risk factors that someone may want to assess for, both prior to prescribing and then during titration or increasing dosage, and then during maintenance. What are some of the concerns? And there are things that we talk about or we assess for as dietitians of poor dentition, not being able to chew foods well, having access to safe and affordable foods. What is someone's food security status? Any sort of history of disordered eating or eating disorders, mood disorders, GI symptoms prior. And then again, reassessing it as someone increases their dosage, and then once they get to a maintenance dose. So these are things that we as dietitians live in, that we do on a regular basis. But for a primary care provider who may not be doing this regularly, this is a good reference document with some good visual figures for them to be able to fall back on and to be able to know what generally they can do that is within their scope. And also when to refer. So there are some notes here of how, when to potentially refer a patient to a dietitian. We don't have evidence base that everyone needs to see a dietitian who goes on these medications, similar to any other chronic disease medication treatment. But there are likely some individuals who would benefit from more intensive nutrition support.
I like that a lot. I think, we talk a lot about comprehensive care and, a lot of the discussion that's out there about the different kind of programs that are popping up around medications where, some are just really focused on getting that medication to the patient and they're not thinking about all the other components. This could be a good reference for those groups too, of why these things are important, why we need to assess for that. I think, I really like phrasing it in that, like, it's responsible medicine, it's responsible care to really have that kind of wraparound program, with a component of nutrition, behavior, movement, and all of that, and even some assistance on the financial or the navigating insurance. I mean, you and I know how much work and burnout is associated with having to manage that for a program. So yeah, I think that the comprehensive piece, I'm glad to hear that's part of it. I'm glad to hear there's, specific reference to when and how to refer in there as well.
And I think one of the things to keep in mind here, I don't view this as drastically different in terms of how we approach any other chronic disease management intervention. So we do, from a treatment standpoint, as dietitians, help support, let's say, cardiology or endocrinology, where the dietitian services are available and potentially indicated for many individuals, but not everyone who goes on a lower risk medication like metformin or a straightforward antihypertensive medication needs to have a more intensive behavioral nutrition intervention. But having screening systems for those providers, of a primary care provider prescribing some of these medications, of what are the situations that someone may need that additional support, that aren't evidence-based just yet. We don't have the evidence to support this, but just modeling off of what do we already know in similar areas of practice, and how can we learn from that and leverage that, is something that is really important for anti-obesity medications for right now, because the gears of research are grinding much slower, as they're designed to, than how quickly these may be rolled out in the marketplace. So being able to leverage what we know, but at the same time being very honest about what we don't, and not using that for gatekeeping as well. Not to say that someone would not be able to go on these medications or not have access to them if they weren't able to meet a certain criteria that isn't evidence-based, is also worrisome and problematic, and edges into what we've seen in bariatric surgery for over a decade in systematic weight bias practices and gatekeeping of treatment, that we employ in obesity treatment, but not in other areas of chronic disease management. So lots of caution here in that we don't know as much as we want to in this moment. Lots of researchers working on answering the questions that we all desperately want answers to, but we need to, as clinicians, and then also for consumers, recognize the limitations of what we do and don't know.
I think that's really well put. I also see so many, even dietitians, other, healthcare providers kind of working to figure out how to differentiate their program. I've had so many reach out to me saying, okay, we've got to, so-and-so wants to prescribe the medication. We're going to, try to figure out how we can best wrap around that care, and do that. And I think, for me, one of the best, places to go for training and things that they need to work on for their sort of education is really in, non-biased patient-centered care, for the patient with obesity. And that's whatever treatment that they're on. Right. So I think that there's this urge to have such a medication specific focus that sometimes people are forgetting that, again, in our history with bariatric surgery, we know what works. We know how we need to talk to patients. We know that, to me, the language and the motivational interviewing and the counseling approach is so much more the style that we need to do with those few things, just like with bariatric surgery. Like here's the tips and here's the, things that you need to focus on. So I think there's really a big place for pulling from our history and from others who've been in that field for a long time.
Yeah, and recognizing what likely is not going to be able to get pulled over. So some examples from bariatric surgery, right? We have some pretty strong behavioral programs that are rooted in cognitive behavioral therapy, like the diabetes prevention program, that have decades of research and thousands of participants who have been monitored over extended periods of time, that we know this is effective, right? When we take that content and we modify it for bariatric surgery, we're cognizant of the limitations and the needs of someone who has had bariatric surgery. In that immediately after, we might not be talking about limiting portion size. We're talking about eating frequently enough to meet a minimum. Similar in terms of general discussions and meeting goals. The goals have just flipped from limiting to meeting. And it's slightly different for that time period, but we're still oftentimes talking about similar topics of some lifestyle choices and food choices, of being able to meet high protein, self-monitoring, regular activity, integrating that in, environmental stimulus and being able to help modify that, helping get social support as well. Those are all things that we have been able to utilize and translate for bariatric surgery. And then longer term, we don't really know probably the best approach. Some would argue, right, acceptance and commitment therapy. Others would go back to that cognitive behavioral therapy as like the main core. And if you're not seeing them very frequently, potentially motivational interviewing. And those are all things that we pull from behavioral treatment. Shifting over to anti-obesity medications, right? It's a similar concept in that certain things might not be applicable for the individual. The clinician is there to modify, but we have the behavioral base of content to pull from. That something like triggers of talking about controlling stimulus, controlling the environment might not be as pertinent for someone on an anti-obesity medication, because they oftentimes will say the food noise is gone, right?
Right.
I don't feel like I need to, like the seafood diet that I see it and I want to eat it, that trigger is not there anymore. And that's partially how that medication functions. Going through that content and talking about how it's applicable to them, it might be helpful to discuss that that's a change they've experienced. But having in-depth behavioral counseling around how you can modify things is likely not going to be helpful for them. What we can pull from bariatric surgery that we would not be able to pull from behavioral treatment is going to be symptom management. So when we look at the data around scale trial, around the SURMOUNT trial, the large trials around tirzepatide and semaglutide, we see pretty high prevalence of individuals experiencing GI distress in some shape or form.
Right.
And depending on the type of medication and where they're at in the process, there's some predictability to it, but not per se. So a decent number of people are experiencing nausea, vomiting, diarrhea, constipation. Now, any bariatric clinician will also tell you that there is a significant proportion of individuals after bariatric surgery, for a whole host of reasons, not just the surgery, potentially their medications, the dietary changes, are experiencing these GI symptoms as well. Dehydration is another one, right? For what we know about bariatric surgery, one of the most common causes of a 30-day readmission is going to be dehydration. We also see dehydration as a challenge with anti-obesity medication in patients. So again, using that behavioral foundation and knowing what we know to be able to nutritionally support individuals who have gone through bariatric surgery to modify in the moment, rather than giving them all the information ahead of time, that if you have diarrhea, do this, if you have constipation, do that. Being able to provide that support in real time is likely going to be much more effective. Now, again, we don't have the evidence base that it is required or that not receiving it is a significant detriment to people. But there might be some benefit to it, and we can position ourselves as dietitians to be able to provide that service, while at the same time, those of us in academic positions or with the opportunity to do research to actually be able to measure these outcomes and see whether or not they actually make a difference, and if this is something that should be scaled.
I love that too, because again, knowing how much the behavioral component is important, we we don't want just recommendations that come out that we tell people what to do, right? I mean, that's the age old thing where people just, they glom onto an idea, they tell them this is what you're supposed to do. The people have a struggle to do it for various reasons, and then it's not being done. And so you have that divide between what we're saying is supposed to be happening and then what's actually happening, and the people who are on the medication or surgical patient, whoever, are not actually getting the benefits of those recommendations.
And frankly, we don't know what people quote unquote should be doing just yet. We don't. So purporting that we have that information as a clinician, to me, is really worrisome from a practice standpoint and from a competency standpoint, that we really want to be cautious with how we're phrasing this. But again, going back to behavioral counseling or even bariatric surgery, most people that seek these types of treatments are dieting veterans. They know what they need to do. They have challenges with how to do it. If one dietary approach worked for everyone, we would not have dietetics, right? part of the challenge yet beauty of this field is that we have the ability to help tailor recommendations for individuals, and it is very personal and individualized, and frankly, to an extent, very intimate for people, that this is what they're choosing to eat day in and day out.
Mhm.
And having the opportunity to work with someone on those things is really, to me, exciting, but also leaves a lot of opportunity or a lot of room that judgment and bias and problematic approaches can also sneak their way in. This is likely people who are seeking out these treatment options have experienced a lot of weight bias over their lifetimes and
Yeah.
have, you know, lived in an environment that has been steeped in diet culture. So the concept of treating this approach like chronic disease management may need more support than just saying, do this and move forward. Like we may have some destigmatization around high blood pressure treatment. We aren't there yet for obesity treatment.
Yeah, that's a big focus, and I think the more the more people we invite into this intimate space, I like that word. It's exciting because, as we know, with so many people who have this chronic disease, we need kind of all hands on deck to help get the treatment options and help have the supportive services. But as you said, I think there is a concern that people who have not vested their life into treating people with obesity may not have the support, the empathy, the understanding of what bias and what has gone on in these people's lives before coming to treatment. I think that's a really good point, and that we should continue to focus on, teaching about what bias is and how to, how they can identify it and reduce that in their own practice as well.
Yeah, and I think, frankly, most of my experiences with clinicians, where I've experienced pretty blatant um, weight bias, is that it's not something that someone is doing out of maltreatment or malpractice. It's like a maleficent, like they're trying to help support change in a way that they think is effective, but they don't realize how implicitly biased their structure and systems are to it. And clinicians are notorious for this. Clinicians have extremely high rates of implicit and explicit weight bias for the studies that we have available, and it's worrisome. I'm hopeful that the way that we are talking about some of these medications, patients asking about them, them being I think this is a foundational shift, not only to how we treat obesity as a disease state and we support people who have obesity, but also from a cultural standpoint, how we view weight status as a whole. And I'm really hopeful for that shift. I know that there's been a lot of not so helpful press coverage around medications, but I think nutritionally, this is and also from a cultural and medical standpoint, this is a really important opportunity point for us as practitioners.
Absolutely. Yeah, there's a lot of hope, I think, in this space, and a lot of, again, for being in the space as long as we have, it's really exciting to see more people engaged in trying to figure out how to get the treatment to the people that need it. It's, the media stuff is hard along the way, but it's to be expected. And like you said, it's a lot different for some reason, ethically or morality wise, around obesity than it is around hypertension. I mean, it just is different, and so we have to figure out how to treat it that way.
Yeah. Yeah.
So for primary care providers, you think this is something we should be recommending, we should be sharing, kind of tell me what the thoughts are from that team about, how do we get out the word, and what's next and what's kind of coming down the pike.
Yeah, so I think one of the exciting things is with FDA approval of semaglutide and tirzepatide for obesity treatment by the FDA in the last 3-4 years, and the increased awareness of the effectiveness of these medications. It's really shifting how we approach this. And frankly, the models that we have set up for many groups are not set up to be able to support this type of treatment. So we, from a clinical standpoint, are in a really interesting spot that there are a few different groups and like subspecialty specific obesity medicine providers who are well equipped to be able to provide this care out of the gate. Some primary care providers for having to do monthly monitoring during increasing medication dosage and providing a little bit more intensive support may not be as well equipped for this. So we're in a really interesting spot of that. People are trying to figure out how this is going to work long term and what's sustainable. How can we provide appropriate and adequate care to people, and also refer to higher level care, either to sending someone to an endocrinologist, an obesity medicines provider, a dietitian when needed. Because let's be honest, for the number of people who are these medications would be clinically indicated for, we do not have the capacity for all of those people to see dietitians and to see endocrinologists and bariatricians or gastroenterologists. We just aren't there. There's already a clinician shortage. So building systems that we are able to provide the higher level support to the people who may need it will be a moving target over the next 5 years. And I'm really excited to see where this goes and how systems shift to being able to support people, but also recognizing, again, as dietitians, would we love to see everyone in our office to be able to help provide nutrition support? Of course. We got into direct patient care because we enjoy it, but that doesn't mean that everyone, one, needs it. Two, that we're going to be able to provide access for everyone at this time. So this is going to be a major shift in many ways, but doesn't differ significantly from other areas of chronic disease management in many foundational ways. So for primary care providers, this publication, of course, otherwise we wouldn't have written it, is a fantastic reference point for clinicians to go back to. But there are many researchers, such as myself, that are looking to get more or looking to study more specific answers that many of us have questions about for nutritional support for people on these medications. And we'll have more updates over the next 5-10 years as to what are the best ways of supporting people.
Great. Well, yeah, it sounds like you're going to be busy. I'm glad to hear that research is going on, and I look forward to kind of continuing to bring that to folks so that we can do the best for our patients and get the treatments to the people that need it and provide that care the best way possible. So, well, thank you, Colleen, so much. I really appreciate the conversation, and I'll make sure we link back to the article and any other places that people can get in touch with you.
Thank you for having me, Nina.
All right. Have a good one.